Question. A 75-year-old man comes to emergency department because of right knee pain and general malaise for the past 8 hours. He does not remember any trauma to the right knee. He has an 8-year history of osteoporosis. 3 years ago, he was diagnosed with primary hypertension and started on a diuretic. On physical examination, the skin above his right knee is erythematous and tender to palpation. There is mild leukocytosis. And on arthrocentesis, synovial fluid under polarized light microscopy shows negatively birefringent needle-shaped crystals. We know that we are dealing with, these are basically we are dealing with gout, because we know these are uric acid crystals, monosodium urate, right? So this is uric acid crystals. The question that they are asking us is, the patient's diuretic acts on which of the following parts of the nephrons? From the question we can gather that this patient with osteoporosis and hypertension was started on some diuretic that led to hyperuricemia and gout. And they are asking us, where exactly does this diuretic act? So there are two drugs that we already know can cause gout. One is loop diuretics, they can cause gout, and the other is the thiazides, right? Where exactly do they act? Well, let's see. The location here, A, is the proximal convoluted tubule. And in the proximal convoluted tubule, carbonic anhydrase inhibitors like acetazolamide, they act. When we inhibit the carbonic anhydrase, we are going to excrete sodium, we are going to excrete bicarbonate. It is going to create acidosis-like condition in the body that can definitely exacerbate gout. But we have never heard of acetazolamide being used to treat hypertension or osteoporosis. Like, it doesn't make any sense. So, no, not A. A was basically about the carbonic anhydrase inhibitors, right? Okay, so we are thinking that it can't be this A location because carbonic anhydrase inhibitors, they do not cause hyperuricemia, they are not useful in hypertension, they can be used in glaucoma, altitude sickness and a lot of other things, but not this. Moving on to this location here, B. Now B is basically the location where the osmotic diuretics act. So a drug like mannitol, which is a osmotic diuretic, it is going to act on the descending limb of the loop of Henle and it will be active at the location B. Mannitol, osmotic diuretic, it is going to exert osmotic pull inside the loop of Henle and it is going to like pull all of the water inside, leading to diuresis. It can be used to decrease intraocular pressure or even intracranial pressure. Its side effect is pulmonary edema, but nowhere is it useful in hypertension, primary hypertension, and it is also not useful in any of the conditions that we are dealing with here, like osteoporosis. Other than that, it does not cause any kind of uric acid excretion, like it is not increasing uric acid excretion or it is not having any effect on the uric acid. So we can safely eliminate mannitol. Then moving on to C. Now C here is basically our loop diuretic location. Loop diuretics, they act on the thick ascending limb of the loop of Henle. They are going to inhibit your sodium, potassium 2-chloride channel. By inhibiting this, they are going to cause diuresis. Like water is going to go along with the sodium and we are going to achieve the diuretic effect that we desire. But they are also going to cause your hypokalemia by excreting potassium. They are going to lead to hypokalemia. Okay. Loop diuretics, one of the side effects is gout. Now before we choose this option, we should also know loop loses calcium. By losing calcium, they create a condition of hypocalcemia in the body. This patient has got, as we can see here, osteoporosis. Would we want to give a patient with osteoporosis a drug that causes hypocalcemia? Definitely not. So, loop diuretic, even though it is useful in hypertension and even though it also causes gout, because the patient has got osteoporosis, we can't give a drug that loses the calcium from the body. For this patient, the calcium is very precious because he has osteoporosis. So that's why not loop diuretic. Moving on to the next location, which is D. Now D is the distal convoluted tubule. So in the distal convoluted tubule, this is the location where our thiazides act. All our thiazide diuretics are going to act on the distal convoluted tubule. Thiazide diuretics have the side effect hyperglycemia, hyperlipidemia, hyperuricemia, and they also cause hypercalcemia. The two things that we needed are already there. It causes hyperuricemia, that's how it contributed to the gout, right? Hyperglycemia, lipidemia, uricemia, calcemia, and because it caused hyperuricemia, we got the gout. And because it causes hypercalcemia, that's why the physician must have prescribed it in a patient with both hypertension as well as osteoporosis. It increases calcium. So it seems like we have found our drug and its location. So the correct answer should be D. E is also there, E and F. E and F are where exactly your drugs like aldosterone inhibitors, like spironolactone would act. Spironolactone will act. Other than that, some of the epithelial sodium channel blockers like amiloride would act. Now these drugs are not associated with hyperuricemia, gout, and they are not even used in hypertension. So that's why it is not F. Okay. So therefore the correct answer here is D, which is our thiazide diuretics. They act on the distal convoluted tubule. They cause hyperuricemia, which led to gout in this patient. They also contribute to hypercalcemia, which could be useful because it will retain all the calcium, cause hypercalcemia, and then this patient with osteoporosis, where the calcium is very much needed, it could be a very useful drug. Also, thiazides are one of the first line diuretics that we use in hypertension. So with thiazide fitting in perfectly, the answer here is D. Let's quickly summarize and take a look at all the diuretics at once. So if we take a look at this diagram, we can see that the location number 1 right here, this whole blue part that is going down, proximal convoluted tubule as well as the descending limb of the loop of Henle. This is where the which diuretics act? Osmotic diuretics like mannitol act. They can lead to diuresis and they are very helpful in reducing your intracranial intraocular pressure. But these drugs have the side effect where then we cannot use them in pulmonary edema because it will exacerbate conditions like pulmonary edema. It can exacerbate conditions like heart failure, and also in cases of renal anuria where the kidney is just not able to generate any urine, it is counterproductive to give mannitol. So that is mannitol. It is used. What is its use? Its use is reducing intraocular intracranial pressure. What is its adverse effect? Well, the notable adverse effects are basically it can cause pulmonary edema and it is contraindicated in anuria and heart failure conditions. It can also lead to dehydration, a lot of dehydration, and it can disrupt like the sodium balance in the body, leading to either hyponatremia or hypernatremia. So mannitol. Then moving on to location number 2 here, this is where the carbonic anhydrase inhibitors act. Carbonic anhydrase inhibitors like acetazolamide, brimzolamide, they act here. Once we inhibit carbonic anhydrase, what is carbonic anhydrase doing? It is basically enabling the reabsorption of sodium and bicarbonate in the body. If we inhibit carbonic anhydrase, we are going to excrete sodium. Along with sodium, we are going to excrete the bicarbonate also. What happens as a result of this is you are excreting sodium. That is going to pull water also along with it and lead to diuresis. But when we excrete bicarbonate, that is going to alkalize the urine. When we alkalize the urine, some sort of stones, for example, your calcium phosphate stone, because the urine is now alkaline, it is having a high pH, so these calcium phosphate stone can precipitate. So one of its side effect could be it can precipitate calcium phosphate stone. Other than that, when we give carbonic anhydrase inhibitor, we are removing all the bicarbonate, so it is going to lead to acidosis. It is going to cause acidosis. What kind of acidosis is this? This is a condition of metabolic acidosis. Now, when we are dealing with metabolic acidosis, what we decided was we can use it to our advantage. Where can we use it to our advantage? In conditions that are having alkalosis. For example, metabolic alkalosis. Metabolic alkalosis, we can use carbonic anhydrase inhibitor. Other than that, in case of respiratory alkalosis also, when a person goes to a high altitude, we get altitude sickness. In altitude sickness, what happens is person is going to hyperventilate, and because of all that hyperventilation, the CO2 will decrease in the body. And when CO2 is not there, H plus is also not there, and the person is going to end up getting respiratory alkalosis. So one of its uses is, we know it is one of the most commonly used drugs for altitude sickness. Altitude sickness. So that's it about the carbonic anhydrase inhibitors. We know its mechanism of action. We know the side effects, that it can precipitate some types of stones. It can even lead to sulfa allergies. It can cause hypokalemia. It causes excretion of potassium also. And then where do we use it? We can use it in metabolic alkalosis. We can use it in respiratory alkalosis, altitude sickness. And it is also useful in, it is a very useful glaucoma drug. It is a very useful glaucoma drug. Okay, then moving on to our third location. It is a thick ascending limb of loop of Henle. And the drug which acts here are the sodium potassium 2 chloride inhibitors, which are our loop diuretics. Loop diuretics. What do we need to know very importantly about loop diuretics like furosemide, bumetanide, torsemide is that they can cause sulfa allergies. They can cause sulfa allergies as a side effect. They can lead to a lot of electrolyte imbalance. They can cause hypokalemia. They can cause hypomagnesemia. Other than this, they cause excretion of H plus also. So if there is excretion of H plus happening, then we are going to get what? We are going to get metabolic alkalosis. So they can cause metabolic alkalosis. That's their side effect. Metabolic alkalosis is a side effect of loop diuretics. It can decrease potassium. It can decrease magnesium. Other than this, what happens is these drugs are ototoxic and they can cause gout. So they can lead to they can damage your hearing. They are ototoxic and they cause hyperuricemia. They cause gout. They inhibit the excretion of the uric acid. If you inhibit the excretion of uric acid, it's going to build up inside the body and it is going to contribute to gout. Other than that, what do we know? What are its uses? It's very useful in heart failure. Loop diuretics are the go-to drugs for heart failure in case of cirrhosis, in cases of nephrotic syndrome, pulmonary edema. All these edematous states, loop diuretics are extremely useful. In hypertension also it is very useful. Another thing is that they decrease calcium. Very important thing is that they decrease calcium. Loop lose calcium. Loop diuretics lose calcium and they can cause hypocalcemia. Therefore, it could be a very useful drug in which condition? Hypercalcemia. They are very useful drugs for hypercalcemia. That's about the loop diuretics. Then we move on to the important things that we need to know about this fourth location here. Let me clear it. So number 4 here are the thiazides. Now what all do we need to know about the thiazide diuretics? we have got drugs like hydrochlorothiazide, chlorthalidone, metallazone. These drugs, they are going to inhibit the sodium chloride reabsorption. NaCl channels that are there in the distal convoluted tubules, it's going to inhibit it. So we are going to lose sodium, and along with that diuresis will happen. One very good thing about them is that they can increase calcium. They do not lose calcium. Thiazide diuretics help to build up your calcium. So that is why in this patient with osteoporosis, for example, we had given this drug. Again, the uses are, it is useful, one of the first line drugs for hypertension. In heart failure also, it is very useful when we want to achieve diuresis. In idiopathic hypercalciuria, where we are having lot of calcium being excreted in the urine, which we can give it so that it can increase the calcium. In nephrogenic diabetes insipidus, the mechanism is there such that it is very useful, thiazide diuretics. And osteoporosis, we can use thiazides. What are the adverse effects? What are the adverse effects of thiazides? Well, one of the adverse effects we have already seen. We've already talked about that: hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. And that's all we need to know in terms of side effects of thiazide diuretics. Moving on to location number 5, these are all the potassium sparing diuretics. Now, till now, whatever we had talked about, they were all somehow contributing to hypokalemia. Carbonic anhydrase inhibitors cause hypokalemia. Even the loop diuretics, the thiazide diuretics, they cause hypokalemia. They are all decreasing potassium. The drugs at number 5 here, they are the potassium sparing drugs. They increase potassium. Now, there are two types of drugs that can cause, increase the potassium sparing. So when we talk about potassium sparing diuretics, we need to know that there are two drugs in potassium sparing. One of them are the aldosterone inhibitors. Aldo inhibitors like spironolactone. Other one is the epithelial NAC inhibitors, sodium chloride channel inhibitors. Okay, so sodium channel inhibitors, for example, amiloride and triamtrene. So amiloride, these are the two group of drugs that we see which are potassium sparing. One is aldosterone antagonist and the other is the sodium channel blockers in the collecting duct. We are dealing with the collecting duct now, right? Now these drugs, they can be used because aldo inhibitors, right? So hyperaldosteronism condition, again, if potassium depletion is happening, so they can restore the calcium in the potassium in the body. So potassium depletion states, we can use it. Heart failure, ascites, hepatic ascites, spironolactone is very useful. Then in nephrogenic diabetes insipidus, again, for diabetes insipidus, we had discussed thiazides are very useful. Amiloride is also very useful. Then spironolactone has anti-androgen effect, and that could be useful in certain conditions where the androgen levels are very high. What are the adverse effects? Well, adverse effect is hyperkalemia. The thing that it is used for, it is a potassium sparing diuretic that can be useful whenever there is hypokalemia, but it can also be counterproductive and lead to hyperkalemia, and we know that hyperkalemia leads to arrhythmias. Again, with spironolactone, one of the advantages is we are using it for conditions where there is lot of androgen, but it can even have some anti-androgenic effects. Gynecomastia can occur with the use of spironolactone. And that is it, all we need to know about the diuretics.